This is Dr. Sunil Gemawat. I'm working in Sumerpur, which is situated in Rajasthan, and the district is Pali. I'll be talking about non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs have following groups of drugs. Number one is analgesic. Number two is antipyretics. Number three is anti-inflammatory drugs. The classification of non-steroidal anti-inflammatory drugs consists of non-selective COX inhibitors, that is traditional non-steroidal anti-inflammatory drugs, under which number one is salicylates, that is aspirin. Number two is propionic acid derivatives, that is ibuprofen, naproxen, ketoprofen, and flurbiprofen. Number three is anthranylic acid derivatives, that is mefenamic acid. Number four is aryl acetic acid derivatives, under which diclofenac sodium and aceclofenac comes. Then comes oxychem derivatives, that is pyroxychem and tenoxychem. Number six is pyrrole derivatives, that is ketorolac. Number seven is indole derivatives, that is indomethacin. Pyrazone derivatives, that is phenylbutazone and oxybutazone. Preferential COX-2 inhibitors, that is nimesulide, meloxicam, and nebumetone. Selective COX-2 inhibitors, that is celecoxib, etocoxib, and paracoxib. Analgesics, antipyretics with poor anti-inflammatory action, that is para-aminophenol derivatives, paracetamol. Then pyrazolone derivatives, that is metamizole, propionate. Then benzoxazosine derivatives, that is nefopam. Now we come to the mechanism of action of non-steroidal anti-inflammatory drugs. Anti-inflammatory effect due to inhibition of enzyme that produces prostaglandin H synthesis, that is cyclooxygenase or COX, which converts arachidonic acid to prostaglandins and to TXA2 and prostacyclins. Aspirin irreversibly inactivates COX-1 and COX-2 by acetylation of a specific serine residue. This distinguishes it from other non-steroidal anti-inflammatory drugs, which is reversibly inhibit COX-1 and COX-2. The analgesic effects of non-steroidal anti-inflammatory is thought to be related to the peripheral inhibition of prostaglandin production, which may also be due to inhibition of pain stimuli at a subcortical site. Non-steroidal anti-inflammatory drugs prevent the potentiating action of prostaglandin on endogenous mediators of peripheral nerve stimulation, that is bradykinin. The antipyretic effect of non-steroidal anti-inflammatory drugs is believed to be related to inhibition of production of prostaglandins induced by interleukin-1 and interleukin-6 in the hypothalamus of brain. The resetting of the thermoregulatory system leading to vasodilation and increased heat loss. NSAID and prostaglandin synthesis inhibition. NSAIDs block PG generation. Prostaglandins, prostacyclin, and thromboxane, that is A2TXA2, are produced from arachidonic acid by the enzyme cyclooxygenase. Cyclooxygenase, that is COX, exists in COX-1 and COX-2 isoforms. Now, COX-3 has been recently identified in brain. Cyclooxygenase COX, that is bound to condition. COX-2, that is inducible, is induced in inflammatory cells by pathological stimulus. And COX-3, which is recently been identified, that is in brain. Non-selective COX inhibitors, that is salicylate, which is aspirin. Aspirin is acetyl salicylic acid and converts to salicylic acid in body, which is responsible for action. Pharmacological actions of analgesics, antipyretics, and anti-inflammatory actions. Aspirin is a weaker analgesic than morphine type drugs. Aspirin 600 is weaker than codeine 60 mg, and codeine 60 mg is weaker than 6 mg of morphine. It effectively relieves inflammation, tissue injuries, connective tissue, and integumental pain, but is relatively effective in severe visceral and ischemic pain. Ischemic pain is related to heart. The analgesic action is mainly due to outbounding of peripheral pain receptors and prevention of prostaglandin-mediated sensitization of nerve endings. There is no sedation in case weaker analgesics. Subjective effects are there, well tolerated, or physical dependence is produced. Aspirin resets the hypothalamus high doses, that is 3 to 6 milligrams per day or of body weight, or 100 milligrams per kg per day. Now I'll be talking about metabolic effect significant only at anti-inflammatory doses. Cellular metabolism is increased, especially in skeletal muscles, due to upcoupling of oxidative phosphorylation, increased heat production. There is increased utilization of glucose, therefore blood sugar may decrease, especially in diabetics, and liver glycogen is depleted in case of diabetics. Chronic use of large doses cause negative nitrogen balance by increased conversion of protein to carbohydrate, where plasma-free fatty acid and cholesterol levels are reduced. Effect of NSAIDs on respiration. Effects of NSAIDs on respiration are dose dependent. At anti-inflammatory doses, respiration is stimulated by peripheral and central actions. That is, increased carbon dioxide production and increased dioxide. Hyperventilation is prominent in salicylate poisoning, that is overdoses of aspirin or salicylates. Further rising salicylate level causes respiratory depression and death. To overcome this, we can use N-acetylcysteine. In case of salicylate poisoning, the effect of NSAIDs on acid-base balance and electrolyte balance. Anti-inflammatory doses produce significant changes in the acid-base and electrolyte composition of body fluids. Initially, respiratory stimulation predominates and tends to wash out carbon dioxide, despite of increased production, and respiratory alkalosis occurs, which is compensated by increased renal excretion of bicarbonate, which accompanies sodium, potassium, and water. Still, higher doses cause respiratory depression with carbon dioxide retention, while excess of carbon dioxide production continues respiratory acidosis, which is a harmful condition, which is life-threatening. Now, effect of NSAIDs on cardiovascular system. Aspirin has no direct effect in therapeutic doses. Larger doses increase cardiac output to meet increased peripheral oxygen demand and causes direct vasodilatation. Toxic doses depresses vasomotor centers and tend to fall BP because of increased cardiac work as well as sodium and water retention in kidneys. Hence, the congestive heart failure may be precipitated in patients with low cardiac reserve. Effect of NSAIDs on gastrointestinal tract. Aspirin and release salicylic acid irritate gastric mucosa, causes epigastric distress, nausea, and vomiting. It also stimulates CTZ, urate excretion. Aspirin in high doses reduces renal tubular excretion of urate and can cause renal stones. An effect of NSAIDs on blood vessels. Aspirin, even in small doses, irreversibly inhibits TXA2 synthesis by platelet. Thus, it interferes with platelet aggregation and bleeding time is prolonged to nearly twice the normal value. So there may be, if the doses are higher of NSAIDs, it can cause gastric bleeding. Long-term intake of large doses decreases synthesis of clotting factor in liver, and predisposes to bleeding. Can be prevented by prophylactic use of vitamin K in parenteral form. Adverse effects of and number one is gastrointestinal effects. That is, most common adverse effects of high doses of aspirin are 70% on 70% or more patients. That is, nausea, vomiting, diarrhea, constipation, dyspepsia, epigastric pain, and bleeding, which can cause melena or hematemesis. That is, bleeding, blood vomit, or blood in stool. These gastrointestinal effects are thought to be due to direct chemical effect on gastric cells or gastric mucosa, decrease in production of cytoprotective activity of prostaglandins, which leads to gastric tissue susceptibility to damage by hydrochloric acid, which is present in stomach. The gastrointestinal effects may contraindicate aspirin use in patients with an active ulcer or active peptic ulcer. Aspirin may be taken with prostaglandins to reduce gastric damage or can be taken with PPIs. Decrease gastric irritation by substitution of enteric-coated or time-release preparation of NSAIDs or the use of non-acetylated salicylates may decrease gastric irritation, and then there will be lesser chances of bleeding. Hypersensitivity or intolerance. Hypersensitivity is relatively uncommon with the use of aspirin, hypersensitivity results in rash, bronchospasm, rhinitis, edema, or anaphylactic reactions like shock. Aspirin should be avoided in such patients, those who are hypersensitive to these drugs. Cross hypersensitivity may exist to other NSAIDs, to the yellow dye tetrazine, which is used in many pharmaceutical preparations. Hypersensitivity is not associated with sodium salicylate or magnesium salicylate. Adverse effect. Ibuprofen and all its congeners are better tolerated than aspirin. Side effects are milder than their incidence is lower. Gastric discomfort, nausea, and vomiting, though less than aspirin or indomethacin, are still the most common side effects. Gastric discomfort, nausea, and vomiting, though less in aspirin or indomethacin, but still are the common side effects. Gastric erosion or occult blood loss are rare. Central nervous system side effects include headache, dizziness, blurring of vision, tinnitus, and depression. Rashes, itching, and other hypersensitivity phenomena are infrequent. They are not to be prescribed to pregnant women and should be avoided in peptic ulcer patients. And to avoid all these, we can use PPIs. Nowadays, these raft formation are present in market. We can use those also. Any questions, please? Thank you.